Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Welcome, everybody. And today we're going to dive in to some of the most common investigations we do as preventive cardiologists or even primary care physicians. And that, of course, is your lipid profile. So you went to a doctor, or maybe you just got blood work elsewhere, and you found that your cholesterol is elevated. Now what? Let's try to peel the layers of the lipid profile and give you some guidance. Now, I know there are a lot of people who wish to have very advanced biomarkers, and certainly the holistic heart centers, this is one of the things we do very, very commonly. We investigate advanced biomarkers in our patients, including advanced lipid profiles, and certainly we look at genetics and we pull everything together, the advanced lipid profiles, the genetics, what we know about a patient, and we provide them with so-called lipid type, which is a very specific outline, if you will, or summation of what actually is happening with their lipids and how it's likely to affect their vascular risk. But today we're going to speak about something much, much, much simpler than that, and something that most likely you already have or maybe had in the past, and that's just the basic standard lipid profile. And the reason why I wanted to speak about the basic standard lipid profile is not only the fact that it's commonly available, but also the fact that certain things in that basic profile are very powerful, and you don't necessarily need any additional investigations. You can take steps to reverse some of the findings in this lipid profile without jumping into advanced blood work, without running genetic analysis, just based on the information that this lipid profile is giving you. So you can think of this episode as back to basics. And as always, if you're listening to me on your favorite podcasting platform, thank you so much for being a listener and a subscriber. And there will be some things that I am going to show you that are in a public domain that you can certainly use for your personal investigations. I'm going to walk you through a real life patient's case using the numbers from this particular patient report. So I simply want to kind of give you an idea what's available out there so that you can apply it for yourself. And for that specific purpose, you may want to jump into YouTube and go to the places in this show where I can tell you this is something that I'm showing you, or you potentially can just catch it on one of the reels and whatnot. So let's go into it. First of all, if you've gone to a doc or did your own blood work with whichever means, and you found out that your cholesterol is elevated, what does it actually mean, right? And which cholesterol, what elevation is actually worrisome and why? Now, if cholesterol was a huge villain and was not necessary for us to have, we probably wouldn't have it, because evolution is pretty smart. And during our evolutionary process, we have certainly evolved to optimize ourselves in a way that suited or fostered our survival. So cholesterol is a very important component of our bodies. Cholesterol is manufactured by every single cell in the body. So our cells are capable of producing their own cholesterol. And certainly our liver is a huge controller and producer. It's sort of the manufacturing facility, if you will, of various cholesterol particles. But when people speak about cholesterol, they tend to be very categorical. They tend to say, oh, I have so much good cholesterol. I have so much bad cholesterol. I'm here to tell you, if you're listening to this episode, is that Forget the good and the bad and focus on the ugly. And I'll explain what it means, and we'll certainly go into it in our subsequent episodes. But what you need to understand is that this division into good cholesterol and bad cholesterol is actually quite outdated. Initially, when large populations of patients were investigated with an intent for us to understand how best to guide patients with regard to prevention of cardiac disease and cardiac disease events, the population level investigations were helpful. And in many regards, that's what formed this framework that, for example, LDL cholesterol is bad and HDL cholesterol is good. But as we go on in various investigations, as science evolves, as genetics comes into the picture, we learn that there are various layers to this. And each individual has what we call a lipidome. Now, you heard about a microbiome. And so the lipidome is essentially a collection, a sphere, an ecosystem, if you will, of all the lipid particles that your body is producing. And the body is producing and extracting from food more than just cholesterol, because it's also extracting triglycerides. And it's continuously repackaging the triglycerides and the cholesterol into various particles, right? And so how these particles are regulated between the gut, the plasma, the blood compartment where they actually travel through, the liver, the muscle, and the adipose tissue, our fat tissue, that's what actually comprises the lipidome. So it's a very complex series of interactions. A lot of these interactions are predicated on your genetic makeup, and certainly very, very influenced by the environment, of course, our nutrition, our exercise, our sleep, and so on. So we're not going to today travel through all of this complexity, but I just wanted to put a little kind of seed out there that the way that we're thinking about cholesterol, for example, my doctor said my cholesterol is elevated, but that's okay because my good cholesterol is high. That is not actually entirely true. And this is why I want you to get a more refined take on the basic lipid profile so that you could contemporize it, right? And just go beyond this good cholesterol, bad cholesterol, because it's not really going to serve a useful purpose in giving you an understanding where you need to go and what you should to do. Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. So first of all, lipid profile, basic lipid profile, something that you can get during a routine physical or potentially employee screening, easily accessible. You can probably purchase it online because a lot of current national laboratory carriers now have direct to consumer where you can go ahead and you purchase basic lipid profile, take it to the lab, and they're going to do a venous stick and give you the numbers. The number one thing that I want you to do if you had your lipid profile is to take a look at what it says in a category called fasting. And try to think, did you actually get this lipid profile when you fasted, or was it in non-fasting state? Now, why is that important? It's important because one of the most common elevated cholesterols that patients are told about is LDL cholesterol. And of course, the LDL cholesterol, which stands for low density lipoprotein, very commonly in the basic lipid profiles is not a direct measure. This is so-called a calculated measure. So when you look at your blood work, you may see in a little parentheses next to the LDL number, it says calculated. Or sometimes it doesn't say calculated, it just says LDL-C, and this capital C stands for calculated. Now, under most circumstances, the LDL calculations are actually not very different from the direct measurement of LDL cholesterol. They're actually pretty good approximations. But there are certainly groups of patients where the LDL calculation will not be useful because it is erroneous. And usually these type of patients, what they have elevated triglycerides, typically above 200 and so on. Now, why fasting? The formulas for LDL calculation have been standardized for fasting blood work. Now, in practical terms, obtaining fasting blood work is not always easy for an individual. And very often, when your physicians refer you for the blood work, they may actually say, oh, you can go and get it, at any time. I disagree. And the reason why I disagree is because most of the cutoffs that we rely on trying to figure out what is the lipidome and the cardiometabolic or metabolic influence on person's lipids, these cutoffs came from fasting specimens. While there is literature that supports non-fasting values and potentially tells us that elevation in values that are obtained in non-fasting states, for example, for triglycerides, might be relevant, we don't have a way to standardize those non-fasting numbers. So if you had a lipid profile, check whether or not you got it in a fasting state. You may remember, maybe not. And by fasting, I mean, have you actually fasted for at least 8 hours prior to getting this lipid profile done, right? Because we want to remove the influence of non-fasting circumstance where your blood potentially may have increased number of triglycerides, which is reflective of you eating food and not being in a fasted state, right? So fasting is the best way for us to kind of standardize this lipid profile information and not to have it in the back of our mind. Are we seeing certain parameters that potentially are influenced by food intake and not so much by what is happening metabolically with our body, right? Obviously, those things are connected, but you want to remove the influences. So what is actually influenced by the food intake and why? In the typical basic lipid profile, and this is kind of your instruction or your homework number 2, there are several components. So the basic lipid profiles typically contain total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. And that's sort of the basic profiles as they are. Sometimes the laboratories will actually provide you with something called non-HDL cholesterol. And so we'll speak about that. And occasionally, depending on who your doctor is and if they actually requested this particular measurement, you may have something called ApoB in your lipid profile. Now, ApoB is not necessarily part of the basic or standard lipid profile, but depending on the laboratories, this is basically what might be included by your doctor into this profile. So what are we looking at then with regard to these lipid profiles? What are the things that we want to see, and what are the things we need to know? We need to know the LDL cholesterol, the HDL cholesterol, the non-HDL cholesterol, and of course your total cholesterol, and if it was included, your ApoB. Why is this important? Now, this is important because studies have shown us, I'll do it in a very complicated way, that each of those measurements is relevant to the risk of heart disease. And yet, those measurements are not necessarily irreplaceable or substitutable one over the other. You kind of need to look at the entire picture in order to figure out where a person is. And that takes us to this concept of your lipid type, right? Remember that in the body, in your lipidome, there aren't separate buckets of these lipids, right? The LDL cholesterol, the HDL cholesterol, while we can certainly identify them by measuring them in the lab, they don't really exist independently of each other. They're related because as we eat, and we consume triglycerides, we consume cholesterol, we deliver it to the bloodstream, we deliver it to the tissues of the body, we deliver it into our liver, and there in the liver, it goes through various processes of transformation as well as in your bloodstream. And these lipid particles, the one that carry cholesterol, carry triglycerides, they change in their composition. They sort of transform one into another. It's a very complicated process. It is predicated on your genetic machinery. It is influenced by environment, and certainly highly complex and not even fully understood. And we learned over time that certain parts of that process, they give us an understanding or relationship to cardiovascular risk. So let's go into that basic lipid profile and say, what potentially should you be looking at and how important it is for you to have certain numbers in certain range and what potentially the numbers that are outside of that range could actually tell you. Now, in general, people would accept that in a low risk situation, right, an individual who in vascular terms is not necessarily at increased risk of vascular disease, heart disease, such as myocardial infarction or cardiac death. What are the numbers that we can look and sort of hang our head on and say, it's okay for this person to have this level of cholesterol? Now, we'll talk about risk in a minute, but let's take a good case scenario, right? So in general, most people would agree, and this is what's documented in the guidelines and various professional society studies, that we would consider total cholesterol of 200 or less to be an acceptable and normal range for most individuals. Now, you might be a little bit below that. You might be a little bit above that. You're not likely to have your total cholesterol measurement influenced by food. So remember that that's not one of those numbers where fasting cholesterol is required. But as I said before, fasting is the best circumstance because all of the calculations that typically go into the lipid profile, as well as the measurements of triglycerides, have been derived in the fasting state. So most practitioners and most of the clinical experts and society experts would agree that if you are at low risk of heart disease and have a very favorable risk factor profile, you can have your total cholesterol somewhere 200 or less, and your LDL cholesterol less than 130, and your non-HDL cholesterol less than 160. Now, so what is non-HDL cholesterol? Very simply, it's your total cholesterol minus the HDL cholesterol. Now, we know that LDL and HDL cholesterol, even though they are in that lipidome relationship, are doing different things. And we know that LDL cholesterol has been implicated or related in population studies to the risk of heart disease and heart disease complications. As it turns out, in the more sophisticated or more contemporary investigations, we came to realize that LDL cholesterol is only a surrogate marker of the real bad guy. And, and this is what I call not good, not bad, but ugly, right? So the really ugly cholesterol marker is something called ApoB, which gives us a total burden of all atherogenic, meaning promoting or generating vascular disease cholesterols, right? It's sort of a global marker. And we'll have a separate show on ApoB and cholesterol particles, things like LDL particles and HDL particles, because it's a very interesting and complex subject. And I really would like to focus on it in its own separate discussion. But for now, just know this. The ApoB is essentially a sum total of all cholesterols that are capable of damaging the arteries. That's how you can think about it. It's just sum total of all cholesterols that are capable of damaging the arteries. Most of it is LDL cholesterol, but there are others. There's something called very low density lipoprotein. There's certainly something called chylomicrons, which are these, giant kind of bowls of triglycerides that we bring over from our gut, that deliver triglyceride from our food to our bloodstream and to our tissues. So there is a lot in that ApoB, and you can think of it as really this massive basket from which different type of lipids could potentially come out and cause damage. But everyone would agree that if you're a person who is at low vascular risk, you really could have LDL cholesterol numbers and non-HDL cholesterol numbers, which are not necessarily as pretty as we would like them to be, but they're okay for you because you are not at a high risk of events, right? Obviously, as one gets older, one potentially could cross the territory from low into high risk. But for now, if you're a low risk individual, let's agree that this is something which is fine for you. Now, the risk changes and what your cholesterol numbers recommended cutoffs should be changes with regard to your risk profile. Not everyone is fortunate enough to be in that low risk group. So what are these major risk factors? Well, obviously, older age, diabetes, high blood pressure, chronic kidney disease, cigarette smoking, family history of heart disease, especially in first-degree relatives, mom, dad, who were young, 60 or younger. And then there are additional risk factors, or what we even call risk enhancers. For example, obesity or having preeclampsia if you're a woman and you have given birth, having high inflammation level, having certain genetic markers, whether those are monogenic, meaning from a single gene like ApoE4, or polygenic, meaning from multiple genes where there isn't really one single gene that is causing trouble, but a few of them added together potentially might set you apart from the rest. So we recognize in cardiology, in prevention, if you are not at the low risk, we recognize additional levels: moderate risk, high risk, very high risk, and extreme risk, right? And depending on where you may be fitting in the risk equation, your standard lipid profile might either be normal, a little bit abnormal, or very abnormal, right? And so let's go through this so that you understand. So once you get your fasting lipid profile and you know what your numbers are, we're looking at total cholesterol, LDL cholesterol, HDL cholesterol. We're going to calculate non-HDL cholesterol. I mentioned ApoB, but we're going to relate this to your vascular risk, right? So low risk is great. It means you don't have any risk factors. Now, moderate risk is that this is where you have a couple of risk factors for heart disease. And then we also will employ one of those cardiovascular disease risk calculations, and I'll show you what those are. And your 10-year risk based on those calculators is less than 10%. So which means each year, let's say for the next decade, your risk of having a heart attack, a stroke, or dying from vascular cause is less than 1% per year. And this is what we call is moderate risk. Now, for patients at moderate risk, studies suggest that the LDL cholesterol calculated, because remember, most of these are calculations, should be less than 100. Your non-HDL cholesterol, which is total cholesterol minus HDL, and that's an approximation for all of the cholesterols that potentially could cause issues with the blood vessels. Of course, as I said before, ApoB is best for this, but if you didn't get ApoB measurement, that's okay. You can use non-HDL cholesterol. You can calculate it very quickly in order to figure out an approximation as to where you stand with regard to vascular risk, right? So 2 risk factors, your 10-year risk less than 10% typically means that your LDL cholesterol should be less than 100, your non-HDL cholesterol should be less than 130. Usually LDL and non-HDL cholesterol are about 30 milligrams per deciliter apart. That's in American units. And your ApoB, if you did get it measured, should be less than 90. Right? So you could see that, this is a little bit stricter than for a person who is low risk. Now, who are the high-risk individuals? The high-risk individuals are individuals that may belong to either a group where there is diabetes or they have chronic kidney disease, usually stages 3 to 4, so sort of pretty advanced chronic kidney disease, and they don't really have any other risk factor. Or they have a couple or more risk factors, but based on the combination of their lipid and non-lipid parameters, this 10-year risk now lives between 10 to 20%, roughly. Some gradations are a little bit finer, from 7.5 to 11, but 10 to 20 is easy for us to remember. And some of the practice documents and clinical guidelines actually aim for that bracket, right? So if you belong into that group of patients, then you essentially are maybe trending into the very high risk category. That really depends, because you might be somebody who has a genetics for so-called heterozygous familial hypercholesterolemia, fairly rare disorder, or maybe in the past you had hospitalization for heart-related issue, or you have some carotid plaques. And we're going to go into some of our episodes pretty soon into your vascular age and what carotids actually tell us about your vascular age, or perhaps some atherosclerosis in the legs. We call it peripheral vascular disease. So there could be these mitigating circumstances. And if someone is fitting the bill on these particular clinical issues, especially if they're diabetic or have kidney disease and have one or more risk factor, then we really want that LDL cholesterol to get to less than 70 and ApoB to less than 80, and your non-HDL should be less than 100. So you could see already how this determination from your very basic lipid profile really depends a lot on where you are with regard to your risk. And finally, we have recognized in cardiology that there is actually a group of patients who we call are at extreme risk, right? Not just very high risk, but extreme risk. And these are really patients who have progressive cardiovascular disease. They have unstable angina, they have MIs, and they already achieved this LDL cholesterol less than 70 and ApoB less than 80, and they're still having an event. Or they have established heart disease and they're diabetic and they have kidney issue, or maybe they have a very strong genetic predisposition, or perhaps they have a history of young relatives. Less than 60 is sort of a rule of thumb, but you may find a more stringent cutoff, less than 55-year-old in a male, less than 65 in a female, somebody in the family, usually primary degree relative, who had a serious cardiac event. Now, for those patients, we may aim to get to LDL cholesterol of less than 55 and ApoB less than 70, because at those levels, there is actually some literature that shows us that there potentially is plaque regression, right? So there's potentially healing effect of such low levels that we may tap into for these specific patients. So let's hope you're not into the extreme risk of very high risk group, but you'd like to know what is your risk, right? Let's say you don't have diabetes and don't necessarily have those family members who unfortunately had heart attacks or strokes when they were young. You're just are, as a majority of most perhaps middle-aged adults who, for the first time or maybe for the second time, have been found to have elevated levels of cholesterol, and you want to put it in context. Now, putting it in context is important, and we have several ways how we can do this. So there are a number of these calculators, if you will, that are available to us that allow us to understand what person's risk potentially might be like. So one of the very well-known calculators is so-called atherosclerotic cardiovascular disease risk estimator. Now, a lot of this information has been obtained from guidelines that were put out by American College of Cardiology in 2018, the cholesterol management guidelines. This year in 2025, I will be traveling to European Society of Cardiology, and they will be actually unveiling the European version of the cholesterol guidelines, a newer version, really a revamped version. But let me walk you through the example. This is in the public domain. You can find it online. I'll put a link for it in the show notes so that you can certainly use it. But let's look at a real example. So this is a patient that I saw recently. This patient is 59 years old. It's a female patient. Her race is white. And her systolic blood pressure was 132. Her diastolic blood pressure was 85, which is actually not uncommon. There are very many people who have this type of blood pressure. And her total cholesterol was 234. So we'll go back here and we'll say it's 234. And this was a fasting measurement. Her HDL cholesterol was 42, and her LDL cholesterol is 168. So we're going to go here. Her HDL cholesterol was 42, and her LDL cholesterol is 168. And so this patient is not a diabetic. She has never ever smoked. She is receiving some hypertension medication. She is receiving statin therapy because that's what she was started on, and she had enough symptoms to warrant aspirin therapy, right? So what are we seeing here in this calculation? We're seeing here that this is a fairly young patient. She's only 59 years of age. She's already receiving all appropriate therapies. And by receiving her appropriate therapies for her level of risk, her current 10-year risk of atherosclerotic cardiovascular disease is 5.9%. So this is sort of in that borderline group, right? Notice, as it is for most patients who are young, the lifetime risk is always high. It's about 39%. If all of her risk factors were appropriately controlled, she, however, would drop her 10-year risk threefold, right? Let's assume the patient doesn't want to be on a statin drug, right? This is a very common scenario. No, she's not on therapies, and no, we're not running any comparisons. And you could see here that still, because, even though her numbers are not particularly newsworthy, she kind of in that intermediate risk group, and we can go ahead and we can view the advice that this particular patient will be receiving. And based on this calculation, we will be offering this patient an advice to consider moderate intensity statin, especially if there are other risk enhancing factors present, right? So her cholesterol profile, which is not particularly screamingly bad, right? She doesn't have LDL cholesterol of 190 or higher. Still, there are things in it, and we can do a lot of stuff to modify her risk. And we will be looking for something called risk enhancers. We will be looking for things that we can measure and decide upon whether or not it's her ApoB levels, whether or not it's her triglycerides levels, whether or not her coronary artery calcium score, to have a discussion with this patient as to whether or not she merits a medical treatment with a statin drug, or can we lean in more and aggressively into her lifestyle to actually help her along. And a lot of it will depend on her clinical stuff. For example, is she diabetic? Did she ever have preeclampsia, right? I told you she's a woman. Whether or not she is actually amenable to lifestyle intervention and willing to go at it. But there is something much more important in her lipid profile. And, I just showed you a very basic lipid profile that almost everybody can get. And this is a very well-established calculation that most patients can get. And this is actually a calculation that most likely your doctor may be doing when you go and see your doc and you decide together with your doc if these numbers are good for you or not so good for you. But there is something here in this risk estimator that is not shown right now that is so important, and actually it holds the key to reversing some of her mildly elevated lipids. And so what actually is that very powerful variable that could give us a clue what the lipid type of this patient is? Now, you notice that this particular calculator is not really giving us an opportunity to input anything else. There are newer calculators that we have. One of them was recently provided. It's called Prevent, and it received a bit of a criticism because some of the calculations in this newer calculator really have showed that majority of patients that we thought who potentially may need statin medications may not actually need them. So there's been a lot of criticism over that, and investigators are still working on revamping this calculator. But there's a lot of good stuff that it provides, because in addition to just cholesterol numbers, age, gender, and ethnicity, it also allows us to incorporate things such as kidney function, for example. It allows us to focus on glycemic control by incorporating hemoglobin A1C. It even allows us to use certain things that tell us about social circumstances of our patients, including, for example, zip codes, so their exposures to environmental influences and the BMI. But because of the criticism, this calculator has not really been used as much, even though it is the newer one. And certainly, as I already said, it requires things that you may not necessarily know, or your physician may not necessarily know. So our goal is to continue to stick with the basic lipid profile as much as possible. Now, there are other calculators that have been helpful. For example, Dr. Ritker and his group have launched something called Reynolds Risk Score. It is primarily focused on female patients, and so it would be applicable to this patient. So let's say if we go and we plug in her numbers, we know she's 59 years old, she's 132 is her systolic blood pressure, she's not a diabetic, she's currently not not smoking. And as I said before, her HDL cholesterol is 42. And by the way, HDL cholesterol over 40 is considered reasonable. Now, women tend to run higher numbers. So typically for a female patient, we'll look at 50 or more. But here, her HDL cholesterol is 42. And we said previously that her total cholesterol is 234. So we're going to plug it in into this calculator. And we're going to go ahead and let's say her C-reactive protein. Let's give her, she was at the intermediate number. She was actually 1.2, and no one in her family had a cardiac event. So you could see here that it's giving her a 10-year risk of a Myers stroke of 3.3%. Right. So again, we don't necessarily think that this person would benefit from statin therapy. So what should this person do in order to normalize her lipids? Because remember, I did tell you that even though we are predicating the numbers with regard to what your cholesterol should be based on your level of risk, you probably are going to say, okay, well, this lady, she has a couple of risk factors. Maybe she's at moderate risk. She's hypertensive. She's being treated for that. She is overweight. So really, even though her LDL cholesterol, what it is right now is 168, the guidelines really tell us it should be less than 100, right? And so how can we help her to get there? And that brings me to a very important ratio that may not always be reported on your blood work. And you can go ahead and take a look if this ratio has been reported on your blood work. But this ratio is super easy for you to calculate. Right? So what you want to do is that you want to know what are your triglycerides and what is your HDL cholesterol. And this is really important because we have this key ratio that gives us a window of opportunity to intervene. Now, remember how I said at the beginning, you must have a fasting standard lipid profile, because if you don't, some triglycerides may be hanging around, reflecting your meal intake. And so they, of course, will be reported as higher than maybe what your baseline is, and they will give you a higher ratio. Your HDL cholesterol is not going to be affected by food, but your triglycerides will be. So let's take this particular patient. And so we're going to do our calculation. And this particular patient, her triglycerides were actually measured as 119 milligrams per deciliter, which by all typical standard medicine criteria of triglycerides is considered to be normal, right? Standard laboratories, not functional medicine laboratories, where we would like to see triglycerides in double and not triple digits, especially in a fasting state. But traditional laboratories, laboratory cutoffs will give you less than 150 milligrams per deciliter as a normal number. And so for this particular patient, that's exactly how it was flagged. It was flagged as a normal number, right? So 119 milligrams per deciliter is definitely less than 150. So it was a normal number. But remember how I said that her HDL cholesterol was actually only 42. And most of the guidelines will stratify women as HDL over 50 being favorable, HDL less than 50 being unfavorable. The criteria for men is less than 40 favorable. So with her HDL cholesterol of 42, what we're going to do is that we're going to divide her triglycerides by her HDL cholesterol. So and you can do it in your head, roughly, you can, for example, say, well, 119 is 120 and 42 is about 40. So 120 divided by 40 is 3. Now we're going to go ahead and we're just going to calculate it exactly. And I already plugged it into my phone and it's 2.88. Why is this number important? You may not find it listed on your laboratory report, but you can sure enough take a calculator, use your phone and calculate it. The reason why this number is important is because the triglyceride to HDL cholesterol ratio greater than or equal than 2.4 is a very strong indicator of insulin resistance. So here is our opportunity, because this 59-year-old person is scoring in low to intermediate risk group without risk enhancing factors, which she doesn't have because she's not a diabetic. There's no one in the family who was young with heart disease. And let's say, for the sake of this discussion, we don't know her calcium score. But the point is that if she just has these basic lipid profile numbers and we plug her into our calculators and all we focused on is LDL cholesterol or even ApoB, we're actually going to miss a super important opportunity to help this patient to optimize her metabolism and to optimize her lipid profile. And that's to recognize that her triglyceride to HDL cholesterol ratio is high, and it's a strong indicator of insulin resistance. Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. So unless there are additional reasons why you may need to consider this patient for a statin medication, the path to optimization of her metabolic profile, her lipid profile, is not based on giving her statin medications. It is based on cardiometabolic intervention, right? Addressing insulin resistance and making sure that we can reverse the factors that contribute to insulin resistance, such as obesity, for example. So this could be a patient who could do very well with low glycemic index Mediterranean diet. That could be a patient who does very well with fasting mimicking diet. That could be a patient who does well with metformin, very inexpensive drug, but very powerful for not only longevity and cancer prevention potentially, but also as insulin sensitizer. There are specific supplement regimens that could be helpful here. GLP-1s, things that everybody knows about, and we specifically use tirzepatide or Zepbound with our patients, also can be very useful for this patient. And that cholesterol profile, that lipid profile, can actually be normalized. And not only her 10-year risk could be reversed or reduced, and it's not really bad to begin with, but her lifetime risk could be significantly affected if we recognize that her lipid type is cardiometabolic. What she needs is the reversal of insulin resistance, and in doing so, her lipid profile will actually respond. And this is why I want you to be equipped with this knowledge about the basic lipid profile. You don't need fancy measurements. You just need to understand several important factors. Number one, did your lipid profile, was it obtained in a fasting state? Because then we can trust the numbers, because most of our calculations and investigations have always been pegged to the fasting state. Number two, what is your level of vascular risk? That really depends on clinical assessment. And this is something you can look up online, or you can ask your doctor, Doc, what is my level of vascular risk? Am I considered to be low risk, moderate, high, very high, or extreme, right? And if, the calculation to figure that out is very well known, this as I already showed you, that's our atherosclerotic cardiovascular risk estimator. Again, it's available online, and we'll have a link for this in the show notes because you can go and plug in your numbers and see exactly what that means. Now, if you're a woman, you may want to use Reynolds risk estimator. And again, I'll put in show notes for that as well. It's been described in women, but can certainly use it in men. There's just not enough data. And as I said, using the newer risk estimates is a little bit tricky right now. But that's what you need to know, right? You need to know, was it a fasting state lipid profile? What are my numbers? And how do those numbers fit? Or how does my risk category fit the numbers? Are these numbers good enough for my risk category, or should they be better? I'm certain that you don't want them to be worse. But number 3, and this is only with the basic lipid profile, is probably the most important, because number 3 holds the keys. And the keys are, we want to know how much of that elevated lipid profile situation is due to insulin resistance. And turns out it is very simple to calculate. You don't need ApoB, you don't need LDL particles, you don't need any fancy measurements. All you need to do is to divide your triglycerides, assuming that you had a fasting lipid profile, by your HDL cholesterol, and you have your answer. And this is what you would actually do with your basic, non-fancy fasting lipid profile. It will give you a guide, a roadmap to try to figure out how you can gain control over your metabolism. Where's that key that opens the magic door that will allow you to normalize? Now, in clinical applications, of course, it is more involved than that. We have a lot of utility comes from us using something called Hartwell Toolkit, where we measure advanced lipid parameters, or we measure genetics, because what that does, it allows us to go beyond these more simple ratios, these more simple measurement sticks. Remember that a lot of the information that you just heard, it really comes from population level studies. And it's great with regard to assigning risk levels to a population. But an individual person in front of us, an individual, may not necessarily fit a certain population very well. And so what we are trying to do is to really understand the lipid type of each patient in particular, because then we're able to tell them, well, so much comes from this metabolic influence, insulin resistance, so much may come from the hormonal influence, yet so much from your environment, and so much from your genetics. And when we create this composite lipid type, we are able to give you a roadmap of how you will actually fix it, right? It's not magic. It's not voodoo. It's not some sort of rocket science. It's not chasing this particular supplement or that particular supplement. It's basically using science, everything that we already know, to really personalize the intervention for you. So look at the show notes, because these tools that I mentioned, they're in the public domain. You can absolutely use them. This show is part of our Statin Overprescribing Solution series. So this is a part 2. You certainly should look at part 1, and there'll be parts 3, 4, and 5. If you have any questions or comments, you can message me through Instagram, Facebook, or YouTube. And I'm looking forward to seeing you guys in the next episode. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Card Centers. If you enjoy the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticcutcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.